So we finally get to take a look at how the thorax and the abdomen are involved in integrated breathing patterns. So obviously the rib cage plays an integral role in mobility, and it's a really an amazing combination of geometrics that allow that emotion to occur, and it's reflective of the type and the angles of the articulations and how they change from the superior to the inferior joints. It's reflective of how the sternum and the manubrium are integrated into that motion, and the elasticity of the costal cartilage is critical in allowing the mobility of the rib cage to occur while providing the stability and the protection that the rib cage has as its primary function. So when I look at the costovertebral and the costo transverse joints, as we looked at earlier, we can see that the axis of rotation is a little bit different between the upper ribs and the lower ribs. So when I look at the upper ribs, for example, the axis of rotation is closer to the frontal plane. So we will tend to see motion, if it's closer to the frontal plane, that motion will tend to occur not primarily, but more associated with sagittal plane motion. And then when I look at the axis of motion for the lower ribs, we start to see that shift towards a more sagittal plane axis, which is going to result in motion through the frontal plane more. So when we look at the motion of these ribs, so when I look at the upper ribs, that motion is occurring primarily in the sagittal plane. So we see an elevation of the sternum and the manubrium, and it resembles what we like to call a pump handle. So the upper ribs have this motion that we refer to as a pump handle action. Whereas when I look at the lower ribs, as that axis starts to orient more toward the sagittal plane, the outer angle of the rib starts to move superiorly. So now we see this motion that is occurring primarily in the frontal plane. So we can say that, and we'll hear this termed oftentimes as the lower ribs occurring, the motion occurring as a bucket handle. So we can see that the ribs, just as the handle of my bucket moves upward, the ribs in the lower rib cage move in an upward direction. So we have a lot of muscles that are associated with the ribs and the rib cage and breathing. And they're typically, we like to call these ventilatory muscles. And the ventilatory muscles are unique. They're kind of cool in that they are they're striated skeletal muscles, but they are a little bit different than other skeletal muscles in about 4 or 5 different ways. First, they have increased fatigue resistance, which means they have greater oxidative capacity, and they tend to maintain repetitive contractions over a long period of time. 2, they contract rhythmically throughout life. Whereas, my quad extends my knee only when I ask it to. The ventilatory muscles are really, again, because they're fatigue resistant, they're going to contract rhythmically throughout life and allow us to maintain life. Third, they work primarily against the elastic properties of the lungs and against airway resistance. So instead of working against gravitational pull, like what we've talked about, through these first couple of courses, now we're talking about resisting motion that's occurring from the elasticity from the lungs and the airways. Now, the neurological control of the muscles associated with ventilation are both voluntary and involuntary. And lastly, what's critical with this is that these muscles are in fact life-sustaining. So any muscle that attaches to the chest wall has the potential to contribute to ventilation. We can recruit different types of muscles depending on the level of intensity that we're breathing. So in quiet breathing or at rest, we only typically have inspiratory muscles firing, as expiration is primarily a passive activity. And we can kind of look at what muscles are primary versus secondary or accessory muscles of ventilation. And when I look at the primary muscles of ventilation, we're looking at primarily the diaphragm and the intercostals. So when I look at the diaphragm is really the primary muscle of inspiration. It accounts for 70 to 80% of all the inspiratory force that occurs with quiet breathing. The cool thing about the diaphragm, well, there's a lot of cool things about the diaphragm, but it's circular, and so it attaches to the periphery all along the ribs, down into the we've talked a little bit about the crura before, as it attaches into the vertebral column, but then it attaches into a central tendon. So there's really no bony insertion site that creates this dome-like shape. So the costal fibers of the diaphragm, so these are the costal fibers of the diaphragm, and they originate from muscular slips that are attached to the posterior aspect of the xiphoid process, the inner surfaces of the lower 6 ribs, and the costal cartilage of the lower 6 ribs. So we can see lower 6 ribs as it attaches all the way around. The costal fibers of the diaphragm run vertical from their origin, and they're close to the rib cage, and then they curve to become a little more horizontal before they insert into the central tendon. By looking at an example on this picture, we can see that the fibers come up vertically and then they course horizontally. So these vertical traveling costal fibers of the diaphragm, and again they lie close to the inner wall of the lower rib cage, form a functional unit which is called the zone of apposition. Now the crural fibers here originate from 2 tendinous structures called the right and left crus, and from the aperneurotic arcuate ligament. Now the right and the left crus of the tendons arise from L1 and L3. They pass ventrally and medially and join together to form an arch just ventral to the aorta. So they form that arch here. The lateral arcuate ligament covers the quadratus lumborum muscle and extends from the transverse process of L2, 3, and L1, 2, and 3 up to the 12th rib. So we have a arcuate ligament, a lateral arcuate ligament that runs this way. When I look at the intercostal muscles, we have external and internal intercostal muscles, and they are again categorized as inspiratory muscles. But really the important ones are the innermost intercostals, and they are typically termed the parasternal muscles. And that's that portion of the internal intercostals immediately adjacent to the sternum. So immediately adjacent to the sternum. So the internal and the external intercostals connect to the adjacent ribs, and they're named really according to their anatomic orientation and their location. So the internal intercostal muscles that arise from a ridge on the inner surface of ribs 1 through 11 insert into the superior border of the rib below. The fibers of the internal intercostal muscles lie deep to the external intercostal muscles, and they run caudally and posteriorly. The external intercostal muscles originate on the inferior borders of ribs 1 through 11 and insert on the superior border of the rib below. The fibers run caudally and anteriorly at an oblique angle to the internal intercostal muscle. So we have an external intercostal muscle, and we have an internal intercostal muscle, and those fibers are running in oblique directions corresponding to a approximately 90-degree angle. So that again creates a greater ability to generate force and motion between the ribs. So the last set of primary ventilatory muscles are the scalenes. And the scalenes are primary muscles of quiet ventilation. And as we've learned previously, they attach to the transverse processes of C3 to C7 and into the upper borders of the first rib and the second rib. And their action is to lift the first two ribs, and because of that attachment, they lift the sternum. So that helps in the pump handle action of moving the upper rib cage. So the scalene action becomes prevalent at the onset of inspiration, and it increases as inspiration gets closer to total lung capacity. So their length tension relationship is such that the scalene muscles allow for a generation of a greater force late into the respiratory cycle, especially when the force of the diaphragm is beginning to decrease, because now it has reached its length tension relationship where it can't generate as much force. Now the other component that the scalenes do is it functions to stabilize the entire rib cage. So the scalenes counter the paradoxical movement of the upper chest caused by a decrease in the intrapulmonary pressure, which is created when the diaphragm contracts. So as I had mentioned, really any muscle that attaches to the ribs is going to be have some impact on breathing. So we can look at what are the accessory muscles of ventilation. And these muscles assist with inspiration or expiration, depending on what the level of need is. So when the thorax is stabilized, the accessory muscles of ventilation move the vertebral column, move the arms, move the legs, move the head. But during times of increased ventilatory demand, the rib cage can become the movable segment. And the accessory muscles for inspiration may increase chest motion. So accessory motions of expiration move the diaphragm upward and the thorax downward and inward. And the most commonly described accessory motions are the muscles that we're looking at. So rectus abdominis, obliques, pec minor, pec major. So these muscles are all going to be responsible for compressing the abdomen, compressing the ribs, and increasing the expiratory force. I always look at the best example of stabilizing extremities. Watch at the end of a 400-meter run or an 800-meter race, and as the athletes cross the finish line, what's the first thing they do is they come to a stop. They'll put their hands on their head, or they'll put their hands on their knees, and they'll stabilize their upper body so that their shoulder scapular stabilizers that attach to the ribs and the spine have the opportunity to assist in breathing, so in a reverse action. So that's a typical example of what we might see for in terms of accessory breathing muscles. So let's take a look at motion at the ribs and muscles responsible for this inspiratory activity, which is really an elevation of the ribs and depression of the diaphragm. So kind of just to summarize what occurs, we can look at, starting with the diaphragm. The diaphragm contracts and the central tendon moves caudally. So the central tendon is moving down. The paraspinal and the scalene muscles stabilize the anterior and upper chest wall. So we have scalenes, and so we have the scalenes, and what's not visualized here is the parasternal muscles that are stabilizing the anterior upper chest wall, which helps to prevent a paradoxical inward movement, which is caused by the decreasing pressure in the thoracic cavity. Now, as the intra-abdominal pressure increases, the abdominal contents are displaced down and out, so our deep transverse abdominis, internal obliques, primarily transverse abdominis, becomes active and helps to stabilize the abdominal cavity. Now, when I have continued shortening of the costal fibers of the diaphragm, the lower ribs are pulled up and laterally, which results in that bucket handle motion. So here we have an example of our bucket handle motion. Now, when I continue to have Now, when I have continued inspiration, the parasternal muscles, the scalenes and the levator costorum muscles, they actively rotate the upper ribs and elevate the sternum to create that pump handle. Now, the lateral motion of the lower ribs and the anterior motion of the upper ribs and sternum all occur simultaneously. And then when I look at expiration, at rest is a passive motion, it's a passive activity. And as a result, there's no significant muscular activity associated with it. Now, when I look at active expiration, we can see that the internal intercostal muscles are big assisters in forced expiration. Remember, resting or passive expiration, resting expiration is passive in nature. But when I have to increase my load, or I'm getting increased ventilatory activity, I'm starting to breathe harder, I'm coming around the corner, I'm out running, I'm out jumping, I'm out playing sports, and I start to have increased muscular activity, we can see that the ribs are actively pulled down, and they're pulled down by the intercostals, they're pulled down by the stratus posterior inferior, and then abdominal pressure is increased by our abdominal cavity. Our abdominal muscles, our transverse abdominis, our internal obliques, all those muscles are responsible for increased abdominal pressure, which then drives the diaphragm superior, drives it back cephalidly It increases the thoracic pressure, which then in turn increases the expiratory force. So now we've got an idea of what things look like from both an inspiratory perspective and an expiratory perspective, and the relationship that the diaphragm, the transverse abdominis, that the internal obliques, that the intercostals, the both internal and external intercostals, the serratus posterior, the pectoralis minor, all these muscles that play a role, the scalenes, they play a role in normal breathing, and the differences that normal breathing have at rest and then with activity when those demands start to go up. So make sure we have a good understanding of that relationship, because it's vital for understanding both normal motion and motion during activity and exercise.